The screen is visible.
Oh, okay. So can everyone hear me?
Yes, ma'am.
Yes, okay. So the title for my talk today is Prescribing for Refractive Errors in Infants and Young Children. As you can imagine, this is a pretty big topic, and I really thought about covering everything within 1 hour, and it just didn't seem like I was doing justice to you all by talking about all types of refractive errors, which includes hyperopia, myopia, and astigmatism. So I instead have decided to just focus on hyperopia for the next 40 to 45 minutes, mainly because this is one of the most common refractive errors in young children, and there is a lot of nuance involved in prescribing for hyperopia. And so I hope to talk to you about some of those nuances and considerations when it comes to managing this type of refractive error. And so I'm going to use a case-based approach to present three different cases of hyperopia in different age groups and what are the considerations that goes into managing or treating that hyperopia based on age and other factors. So we will start with just the case presentation, and then we will go into considerations. We will come back to our case to see how those considerations will help us apply our gained knowledge to those cases. And then I will end with some patient education tips that are really sort of important when it comes to the overall management, because our decision making and prescribing for the refractive error is one, but equally important is talking to parents as as patients based on their age about how to adhere to the treatment so that it is successful for them. Okay, so for the first case, this is an 11-month-old female that presented for her first eye exam. And the main reason for the visit was that the father was a childhood amblyope with a history of patching, and they wanted to make sure that the child wasn't developing amblyopia. So this family was really sort um, uh, of sort of keeping things in the radar, and they are following up early on. In terms of pertinent birth history, you can see that she was a twin, and she was born a little premature for a twin. And she had some difficulties with swallowing and breathing, so she was briefly hospitalized. So there is some pertinent birth history, nothing that is too remarkable or concerning for us. And she was enrolled in Okay. She was enrolled in early intervention for some early gross motor issues that the pediatrician had detected, and the OT occupational therapist was working with her on. Okay, so in terms of findings, I have just highlighted the pertinent findings in this case, as well as in the other cases that I will talk to you about. Assume that ocular health, so anterior posterior segment, is all unremarkable, and we'll just go through the findings listed in the tables. So given that she's an 11-month-old child, we did the teller acuity cards, which is a form of grating acuity. And you can see that for findings, you can measure the teller acuity both in cycles per degree or cycles per minute. You can also capture vision in terms of Snellen equivalent that the card itself provides. And so you can see for her right eye, she was around 20 to 80, and for the left eye, she was around 20 to 60. For cover test, we were only able to measure the test reliably at near because she was a very young child. And oftentimes, for such young children, it's really difficult to sustain their fixation reliably for far distance. And so the best we could get is a near cover test, and she was orthophoric. Dry retinoscopy was +5 sphere in each eye. And you can see that after cycloplegic retinoscopy, or cycloplegic installation, we found a little more hyperopia with some anisometropia as listed there, with some astigmatism in both eyes. So, this is our first case. Now, let's sort of slice and dice some of the findings here. So this slide basically is a reference table for normative values for teller acuity cards. And you see these graph. So this graph is available for monocular acuity as well as binocular acuity. And what the graph inside contains are the 90% and the 95% confidence intervals. Sorry, 99% and 95% confidence intervals. Those are the two bars here. And so what that means is that for a vast majority of patients, your visual acuity will fall within those limits. And so for our patient, given her age, so age is here in the x-axis, and then the acuity in cycles per degree is on the y-axis, you can see that her findings for both her right and her left eye are outside norms. So her vision is poor. All right, so that is case one. We have our 11-month-old with high hyperopia, anisometropia, and some astigmatism. Let's move on to our second case, a slightly older child, a 4-year-old male presented for his first eye exam. And the reason for this exam was that the school that he was enrolling in needed documentation that his vision was tested and he went through an eye exam. Besides that, the parents as well as the child himself did not have any concerns. So they basically were there to just check off a form and make sure that that requirement for school enrollment was met. Other than that, the child's health as well as developmental history was unremarkable. Again, pertinent findings. So visual acuity, I think 2025 is around 6, 7.5 in each eye at distance and near. And cover test orthophoric at distance and a very small esophoria at near. He had excellent stereopsis. And you can see that his dry red is plus 125 sphere in each eye, and cycloplegic retinoscopy showed more hyperopia with a little bit of anisometropia in both eyes. Okay, now we're going to switch to case 3. Case 3 is an even older child, 5.5 years old, presenting for first eye exam. And with this patient, he didn't necessarily have any vision concerns or eye concerns, but the parents did note that he really did not like reading books and that every time they sat down to read with him, he would get distracted very, very quickly. And the other thing they mentioned was that his older siblings wear glasses, and the parents wanted to make sure that he didn't need glasses as well. Other than that, the birth and developmental history were unremarkable. Pertinent findings: vision excellent at distance, cover test no strabismus. You can see that his stereopsis is maybe a little bit reduced. Dry retinoscopy, again, mild hyperopia, and cycloplegic retinoscopy, definitely more latent hyperopia with astigmatism in both eyes. So here is the summary of our 3 cases. All of them have moderate to high hyperopia under cycloplegia and no demonstrable strabismus for any of them. And stereopsis in the 2 older kids acceptable. And vision was also acceptable in the older children. In the young child, vision was reduced. So with this information, so we have 3 sort of age groups of children. So let's look at what are some considerations that go into prescribing for hyperopia in kids. So the first question that I usually think about once I have collected all the information, all the way through cycloplegic evaluation as well as ocular health assessment, is to look at the magnitude of hyperopia and ask myself whether or not it's appropriate for their age, right? And then the next question is, what are the chances if the hyperopia is high, slightly or more high for their age, what are the chances of emetropization? And this is a very common question that parents ask, because they want to know, if glasses are prescribed, is this something that the child is going to need to wear for the rest of their life? Or if they had a high prescription without glasses, is that something they are going to retain as they grow older? So it's really important to think about, is the hyperopia appropriate? And then what are the chances that it will go away or the child will grow out of it? And then to follow along, what is the risk of developing strabismus? So strabismus in general, and then with hyperopia, what's more pertinent is esotropia. So what are the chances that the child, if not already, will develop esotropia? And obviously, for higher magnitudes of hyperopia, what are the chances the child will develop amblyopia? And then what are the consequences on visual function? Meaning, is the vision impacted? What about stereopsis? What about ocular accommodation? How does hyperopia affect all of this? Does it affect all of this? And how should we think about for prescribing? And then lastly, impact on literacy or early childhood education. And this question has been added. I've added this to my sort of roster of questions based on recent research, and we'll go through what those studies are telling us. So these questions are not necessarily in the order of importance. I've just sort of listed them all as pertinent questions that you should be thinking about when you have a child with moderate to high hyperopia. So let's tackle them one at a time. We'll start with the first two questions. Is the hyperopia age appropriate? And what are the chances that they will emetropize? So this graph is sort of very famous for the track of cycloplegic refraction and changes from birth to 36 months of age. And this was conducted by the Berkeley Infant Biometry Study Group, the BIBS group. And what you can see are a bunch of colored lines in the graph in the center, right? So each one of those lines are cycloplegic values obtained from infants who were recruited for the study, and measurements were taken at different points during those 0 to 36 months of their age. And so every single line is every single child. So there's a lot of cycloplegic values clumped in that graph. And on the y-axis, you can see the spherical equivalent refractive error. And sort of like taking a 30,000 view of this graph, what this tells us is that at 3 months of age, it's fairly common for kids to have very high hyperopia. So if you look at sort of the track of most of these lines, they tend to be inclined, with the top left part of that line going up. So higher amounts of higher amounts of hyperopia at 3 months of age, and as the child grows older, you can see that the hyperopia is slowly starting to reduce based on cycloplegic refraction. And by about 12 years of age is where this slope comes down, and then essentially the line starts to flatten out after that. Right. So that is true for a good chunk of the kids that are represented by this data. Of course, we do have some outliers on the top and the bottom of that chunk, but for a vast majority of them, by about 12 months of age, the hyperopia that they started with within the first 6 months, they tend to grow out of it and sort of lie at somewhere around 1.5 to 2 diopters of hyperopia at 1 year of age. And then after that, it tends to change, but very slowly over a long period of time. Right. So there's this one kid, as you can see, started off at 0 and essentially ended up becoming myopic. And then there is one kid here who started off with really high hyperopia and ended up with the same amount of hyperopia at 36 or 3 years of age. So those are outliers, but by and large, this is what emetropization is telling us, and this is what we can expect as average amount of hyperopia for a 12-month-old. And keep in mind that our first case was an 11-month-old child. Okay, now what is the probability of emetropization. And this graph actually gives you a probability plot. On the y-axis is the probability. The higher the number, the greater the probability that the child will emetropize. And then on the x-axis, you have the magnitude of hyperopia with the higher amounts on the far right side of the graph here. And so the curve, what it tells us is that the chances of emetropization is greater when the hyperopia is low. So for 2 units or 2 diopters of hyperopia, there is about a 90%, 90+% probability that the child will emetropize. Whereas for higher, as the amount of hyperopia increases, the chances of emetropization slowly starts to go down. Okay, so that's important to remember at 3 months. Okay, one thing to note, especially with emetropization, and this question is still not completely answered in the literature, and we still have some open questions about this, is that, the question of intervention, meaning treatment with spectacle correction, if we intervene and do something for hyperopia at a young age, are we basically messing up or interfering with emetropization? And what this study showed us, this is, I mean, from the Atkinson group, it's a slightly older study, but I'm not aware of any good quality studies like this that are recently published. So what this study did is it followed a bunch of kids and basically put them under three groups. There's the untreated hyperopic group, then the treated hyperopic group, and then there is the control group. And what this study showed us is that at 36 months of age, between the treated and the untreated, the interference of correction on emetropization is not that much. Okay. So the question of whether or not interfering and doing something will that do something to our emetropization, based on at least this study, that is not the case. But it's, you can see that it's an older study and it's not a randomized clinical trial. The sample size is somewhat on the lower side. What we know is that it doesn't interfere, but we definitely need more good quality work to help us answer this question. Okay, moving on to the other two risks that we talked about, the risk of strabismus, mainly esotropia, and the risk for amblyopia. And these two plots are coming from multi-center clinical studies that collected data on a large group of kids. And you can see that, so on the left side is the percentage of children with unilateral amblyopia, and then on the right side, percentage with bilateral amblyopia. And you can see that in patients with high hyperopia, unilateral high hyperopia, the risk of amblyopia goes up with increasing magnitudes of hyperopia. And in children with bilateral hyperopia, the the percentage of kids with bilateral amblyopia or more when their hyperopia is higher. So basically, the higher the magnitude of hyperopia, either in one or in both eyes, you are more likely to develop unilateral or bilateral amblyopia. So the risk goes up with magnitudes, higher magnitudes, basically. And the same thing also applies to strabismus, particularly esotropia. And this is coming from another multi-center study throughout the US that gathered data from patients between ages 6 months to 72 months. So that's 6 months to 6 years of age. And what this risk ratio is telling us is that in patients with higher magnitudes of hyperopia, so the greater the hyperopia, the odds or the risk of developing strabismus goes high. So Keep in mind that this is just a risk ratio or odds ratio. It does not mean that the child will definitively develop esotropia with high hyperopia. It's just that they are more likely than not to develop esotropia. So that's important to remember. And you can also just, if you look at this table in a more nuanced way, looking at hyperopes from 1 to 3 diopters, the odds ratio goes from reference to about 6 times, right? But the minute they cross 3 units, it almost quadruples, so 4 times. And then for patients greater than 4 diopters, it exponentially just keeps on increasing with every diopter of higher hyperopia. So the more the magnitude, you definitely have to look out for a lot of things, including less chance of emetropization, more risk for amblyopia, more risk for strabismus. Okay, now moving, any questions? Please feel free to stop and ask if you have any questions. Otherwise, I'll continue. Um, so recently is less than 10 years ago, a really good study group called the Vision in Preschooler Study Group went to preschools across the country, different pockets of the country, and they measured several metrics in patients, particularly with low and moderate and high hyperopia. And what they are telling us from this study is that compared to kids, so these are 4 to 6 year old children. Okay, so compared to kids with hyperopia of less than 3 diopters, kids with high hyperopia had reduced distance vision monocularly, they had reduced binocular near vision, their accommodative accuracy, so their response to targets of accommodation was very poor, so high lag of accommodation. And then they also had reduced near stereo acuity. So vision and visual functions, these specific visual functions seem to be impacted in high hyperopes compared to low hyperopes. And they have classified high hyperopes as anybody greater than or equal to 3 diopters of hyperopia. And in addition, this is, I think, one of the main purposes of their study group, and it's their most recent publication, is that not only are visual skills affected, what they also showed us is that early literacy skills are also impacted, poorly affected in children with moderate to high hyperopia compared to low hyperopes. And keep in mind that this study, as well as this study, both conducted by the same group, all only looked at uncorrected hyperopes. So this was not a clinical trial. We still do not know whether correcting hyperopia rectifies these deficits. All we know now is that a strong association between reduced visual function as well as poor early literacy skills in kids 4 to 6 years of age with high hyperopia compared to low hyperopia. So, any questions up until now? Okay, so I will talk to you about 2 clinical trials that actually looked at correcting. Hello? Sorry, I thought somebody was asking me a question. So there are 2 clinical trials that actually looked at correcting high hyperopia in young children. So the first trial actually focused on very young children between ages 1 to 2 years old, and they recruited kids between 3 to 6 diopters of hyperopia without any strabismus. And they randomized children to 2 groups of not wearing any glasses, or meaning no treatment, and then glasses group in which they under-corrected them by 1 diopter compared to their full cycloplegic refraction. So one group with no treatment and other group with partial correction of hyperopia. And they followed them up for 6 months, every 6 months for 3 years, right? And then a different trial, again from the same larger group, but focusing on older kids between 3 to 5 years old. Again, same amount of hyperopia. You can see that it's 3 to 6 units. And these kids also had no strabismus, and they had normal visual acuity and normal stereopsis. Again, they were randomized using the same criteria, no glasses versus wearing partial correction. And they were also followed for every 6 months up to a maximum of 3 years. And both these studies, they had some limitations on their target recruitment goal. They wanted to recruit X number of kids, but they couldn't because these kids are really, really hard to find with these strict criteria. But based on the number of children that they recruited, what these studies found was not conclusive. There was no clear evidence of either treatment or no treatment. And so the group concluded to say maybe there is no harm in watching these kids as opposed to prescribing glasses because it doesn't seem like glasses give us a clear benefit, at least from these two clinical trials. But we don't have studies that actually look at the impact of hyperopia on visual functions in older kids, as well as its effect on literacy, which I think will give us very valuable insights into what vision treatment or refractive error treatment can do to overall well-being in children. So the bottom line is that moderate to high hyperopia in infants are less likely to emetropize over time. Studies are showing us that when you provide optical correction at such young age, you are not interfering with emetropization, but clearly more robust studies are needed. The risk for both esotropia and amblyopia goes up with higher magnitudes of hyperopia. And in older children, so preschoolers are usually between 4 to 6 years of age, moderate hyperopia is associated with reduced visual skills, as listed here, as well as early literacy skills. And even though we know that there is an association between hyperopia and all of this, we still do not know whether correcting hyperopia fixes these things. So that's sort of the bottom line when it comes to a condensed sort of knowledge of what we know about hyperopia and the considerations that go into managing hyperopia in young kids. So with that information, before we go back to our case and think about how to apply these to the case findings, just a few tips on evaluation itself. It's really important because if you don't evaluate these children in the right way, then it's basically garbage in, garbage out. Then the findings that you have at hand, you won't be able to make sense of it because they are not measured reliably. So, and I condensed this topic to one slide because this itself could be a 1 to 2 hour lecture. So I'm trying my best to convey the key points here. So especially when it comes to infants and very young children, it's very difficult to test visual acuity. And unlike refractive errors like myopia and astigmatism, so it's easy to based on what magnitude of the myopia or astigmatism helps patients see 6x or 20/20. Whereas in young kids, that is not the case. You cannot often test monocular visual acuity, and very often than not, you will end up with very qualitative assessment of vision, like fix and follow or central steady maintain, because that's what the child was engaging with you at that time for, and so that's the best you could get out of them. So you often will not be able to use visual acuity as a reliable measure to determine whether or not glasses should be prescribed. It should be determined based on all the risk factors that we talked about until now. In older kids, 3 years and above, try to use um, um, acceptable optotypes like Lear symbols or HOTV, and not use, cue giving optotypes like Allen figures, because they can inaccurately give you a vision response. And of course, if a child is old enough for Snellen acuity, by all means do Snellen acuity. And the other important component of evaluation, besides determining the refractive error itself, is doing a good cover test at distance and near. Again, with very young kids, we won't be able to get them to look at something far away. Oftentimes, you will just be left with the near cover test. Again, make sure you use really attentive targets like toys or stickers, to get their attention while you're doing a cover test and estimate the magnitude of deviation. And in older kids, you want to do that at both distances to see whether the deviation changes from one distance to the other. And then lastly, the most important thing, when you are considering treatment, especially for refractive error, is to perform good cycloplegic retinoscopy. So as you saw in all my cases, I did provide dry red as well as cycloplegic values. But many times I don't have the time to do a drier evaluation, because we have a lot of patients to go see. So sometimes we'll just do cover test and then directly put cycloplegic drops so that we can measure their refraction in a most reliable way. And the preferred drops to use is 1% cyclopentolate. And I usually administer that two drops, sometimes 3 drops if needed. And then we perform a retinoscopy 30 minutes after the last drop that was installed to make sure that the cycloplegic effect is maximal when I perform retinoscopy. Okay, so with that in mind, let's talk about treatment. So treatment, again, as I just mentioned, is based on cycloplegic refraction. It really, really is difficult to prescribe for hyperopia, especially in young children, if you don't have good cycloplegic refraction. So I highly recommend you to perform this procedure. So there are two sort of broad ways to think about starting points or what to prescribe for treatment. So this is after your cycloplegic refraction you have in your hand. You can prescribe the full cycloplegic value. So how much ever you obtained with your cycloplegic refraction, you just write all of that in the prescription. And that is usually the standard of care approach if the patient in particular has ESO deviation. And we are talking about, the deviation being a high phoria, esophoria, or it could be intermittent esotropia, or it could be constant esotropia at distance and or at near. So basically, if I see a fairly significant, so significant meaning anything greater than 10 prism diopters at either distances, and if the child has, you know, more than age appropriate hyperopia, my first inclination is to prescribe full cycloplegic values, all of the hyperopia. The second choice is to partially correct them. Now, this opens up a whole can of worms, and we can talk about this for maybe 2 hours on what is defined as partial correction. But a lot of times there is a range of partial correction values. Some practitioners choose to take away +1. So undercorrect hyperopia by +1 diopters in each eye. And then there are a range of practitioners who go up to 2.5 diopters. They will undercorrect it by 2.5 diopters. So you could fall within any one of these ranges and it's fine. It's fine. It depends on a lot of other factors, which again, hard to go into every scenario, but we usually consider partial correction when a patient does not have a sizable ESO deviation. If it is just vision, or if it is just accommodation deficits, or if it is just stereopsis deficits that we see without ESO deviation, then you are within the space of partial correction and you can decide, how much you want to undercorrect, right? So obviously, the more you undercorrect, meaning the more you lie on this side of the range, you are leaving a lot of hyperopia untreated. And so you just need to think about what that would mean for the patient. That means you are leaving a lot of work for accommodation. Is that acceptable? Is that not acceptable? Depends on the patient's age, right? So I usually tend to undercorrect by about 1.5 diopters. That's sort of my go-to. If I'm partially correcting a patient, I will start with 1.5. And if I get the sense that the child will resist wearing the glasses by pushing more plus, in the prescription, then I may go up to a 2. I hardly ever go 2.5, and I'd never go past that. So my comfort range is somewhere between 1.5 to 2 diopters of undercorrection. And, this is very much practitioner dependent. For a lot of people, like I said, they are happy with undercorrecting just one, and a lot of them are really sort of okay with leaving a whole bunch of hyperopia untreated. The other rules of thumb, besides sort of looking at whether it's full correction or partial correction, the other rules of thumb are maintaining full anisometropia. And I will give you some cases to highlight these examples and concepts. So how much ever aniso you are seeing, either as spherical equivalent or as spherocylinder combination, that amount of aniso you want to maintain in your final prescription. And if the astigmatism is significant, usually that's considered anything greater than 0.75 or 1 diopter. Again, if it's with the rule, that's the consideration. If it's against the rule or oblique, even 0.5 diopters becomes significant. So if it is a significant astigmatism, you want to prescribe all of it, full correction, right? So let's go through some examples to highlight these concepts. So we have a 6-year-old in this example with excellent vision at distance and near. And you can see that the child has intermittent alternating esotropia, roughly the same magnitude at distance and near. Dry refraction is +2, so some hyperopia, which again, when you look at that Bibbs graph for a 6-year-old, that's a fairly high hyperopia to retain. You can see that with the +2, her vision goes down from 6.6 to 6.12. But cycloplegic retinoscopy definitely shows you a lot more latent hyperopia. Again, that's one of the main reasons why we do cycloplegic assessment is to unveil all that hyperopia that a child is trying to compensate for, with a little bit of astigmatism in each eye. So for this case, what would be the treatment? Anyone from audience wants to share or put it in the chat? I don't think I can see the chat. Um, Anybody? Can you guys hear me?
Yeah, ma'am. You're audible.
Oh, okay. All right. Well, if there are no takers, then let's walk through what to do. So the treatment in this case would be to prescribe all of what you see in cycloplegic refraction because the patient has a amblyogenic strabismus. Again, esotropia is far more amblyogenic than exotropia. And this is a sizable magnitude of esodiviation for a 6-year-old at distance and near. So the purpose would be to treat and eliminate the esotropia and not worry about, oh, this is going to make their vision blurry now. Um, does that make sense? Okay, let's move on to the next case. So this is a slightly younger child, a 3-year-old. And you can see right away, visual acuity could not quantify in this case. So all we had was fix and follow. Cover test, no strabismus at either distances, and cycloplegic evaluation, +3 in one eye and +550 in the other eye. So spherical equivalent, this child still has about 2.5 or 2.25 diopters of anisometropia. And so in this case, the treatment would be to prescribe because oh, sorry, these values are mixed up between the two slides. So in this case, the treatment would be to prescribe even though there is no strabismus, because the hyperopia itself is high for patients age number 1. So you could think about partially correcting the hyperopia because there is no strabismus, but you still have to prescribe something because the patient has significant anisometropia, which is a risk factor for amblyopia. So when you are prescribing, so here's the example. So let's assume that the child had +4 sphere in the right eye and 650 sphere in the left eye. So that's 2.5 diopters of anisometropia. So in your prescription, that should be maintained. The right and the left eye's prescription should be 2.5 diopters different because that's the aniso that you're getting under cycloplegic refraction. And in this case, given that there is no strabismus, we have partially corrected the hyperopia, meaning we have undercorrected the hyperopia by 2 diopters in each eye. So you took away +2 from the right eye, so that's a +2 for final RX in the right eye, and then you took away 2, the same amount in the left eye, so it's 4.5. And so you undercorrect by the same amount in each eye, and you end up maintaining an ISO that way. So that's the final RX. This is not the absolute right answer. If you ended up undercorrecting by 1.5, that's fine. If you ended up undercorrecting by 2.5, that's fine, as long as you take away the same amount from both eyes. Okay, so let's go back to our 3 cases and see what can be done for each of these cases. So for the first patient, it's 11-month-old with reduced VA, and you have really high hyperopia with anisometropia. So the question is this age appropriate? The answer is it is not. And are they likely to emetropize? Less likely to emetropize given the high hyperopia. And the risk for amblyopia exists, the risk for strabismus exists. And so because of yes to all those questions, you do want to prescribe for case 1. For case 2, excellent vision, no strabismus, excellent stereopsis, no symptoms, right? So this is a 4-year-old, which falls within that 4 to 6 year preschool range that we were talking about. And we learned that these kids can have reduced visual function, early literacy skills could be affected because of hyperopia. In this case, visual function seems to be fine and no parental concerns about education. Granted, they have age-appropriate hyperopia. No, they do not. They have high hyperopia, and they clearly haven't emetropized at age 4. And so this is likely to be retained and may change gradually over a very long period of time. But at this point, with this magnitude, the question is whether or not to prescribe. And the answer would be, given the lack of symptoms, lack of educational concerns, excellent vision and visual function, it is okay to carefully watch this child. And so when I monitor these patients, what I usually tell parents is go through this whole spiel of what can happen in kids with uncorrected hyperopia, meaning, they could have visual fatigue, they could have eye strain, they can develop headaches with near work, they could develop reduced vision at some point. And if their academic performance starts to suddenly take a hit, then I usually tell parents that it may not be a bad idea to try glasses for a period of time to see if it makes it easier for their eyes to to do reading or any type of reading tasks. I think we need to be really careful about how we frame this, because what we are doing is not fixing their um, educational performance with glasses. That is not what we are doing, because right now we don't have evidence, any evidence that it either does or does not benefit the child. What we know is the strong association between uncorrected hyperopia and potential reading deficits, or learning deficits. That's why we can try glasses to see if it can help patients read better and comfortably, to make the task of reading easier. And if I am prescribing, what I will more likely do, assuming that these findings are stable in the future, is to partially correct the child as opposed to pushing full cycloplegic refraction. And then lastly, we have our third case, which is a slightly older child with reading concerns. So if you recall, the parent was saying that the child absolutely hated reading and got distracted very, very easily. But besides that, the eye exam itself wasn't, or particularly visual functions, wherein that severely impacted. Cycloplegic refraction did show moderate hyperopia. So the question is, should we or should we not correct it? And the answer would be to prescribe. But given that there is no ESO deviation, we can do partial correction. And so, what did I end up prescribing for these patients? So, for case one, um, um, that's the young child without the strabismus. So, I did spherical equivalent for the right eye, which is 625, and 750 for the left eye. So, I undercorrected by 1.5 diopters, and I took away 1.5 from each eye. So that leaves us with 1.25 difference between the two eyes, as it did here. And that's partial correction and recommended for full-time wear. And for case three, same thing. I did spherical equivalent because the magnitude was low, and partial correction, removed 1.5 from each eye. So maintained anisometropia in the first case. Okay. So lastly, patient education. So one of the most challenging aspects of treating hyperopia is getting the child to wear the glasses, especially true if the child has no vision issues. If they have perfect 6/6 vision at distance, but if they have this huge esotropia, and with the glasses, if the esotropia gets better, and you can see that in your exam room, it's really hard to help patients understand what is the scope of the prescription. Is it to help them see, or is it to help their eyes stay straight? And for a lot of for many of us, we associate glasses with helping see, right? But in patients with hyperopia, we prescribe glasses for a lot of different reasons, as you saw. And especially in young children, we hardly ever prescribe to help them see better, because we cannot measure what their vision is in a reliable way. So it's really important to educate parents about what the prescription is given for, and that you are helping them, helping their eyes stay straight, or you're helping their eyes function in a certain way. And it is important to let them know that if they have never worn glasses, and if you're giving them +3 spherical prescription for each eye, they are not going to wear them happily from first day. There is going to be an adaptation period, and it's okay to slowly increase wear time for a good 2 to 3 weeks, to help them ease into the prescription. And giving that leeway helps parents understand what they're signing up for when they get glasses. Starting with 2 hours the first day, increase to 3 hours a few days later, 4 hours a few days later, and then gradually increase the wear time to keep it full-time wear. But despite their best attempts, if they have tried this for 3 weeks, 4 weeks, and if the child refuses to wear glasses, I always tell parents to message me so that I can send them a prescription for cycloplegic drops, and they can use that for 2 to 3 weeks on a daily basis so that they are purposefully cyclopleged to help them adjust to the hyperopic correction. And then once they start to wear the glasses full time, you can wean them off cycloplegic drops or stop them. And in patients who have esotropia, if the hyperopic correction helps them, meaning the esotropia goes away with the prescription, please tell parents that when the child takes the glasses off, the eyes are going to cross. And sometimes that crossing is more prominent than how they initially came to you for eye exam. And so you don't want parents to think that the glasses caused the eye turn to get worse. It's just that without the glasses, their eyes are straining that much harder to keep straight. So these are all, I think, just as important conversations to have as the other considerations that you are thinking through in your mind as a clinician when deciding on treatment. So combined with these two, um, is the best approach to managing hyperopia as a refractive error in young children. And with that, I will pause and see if there are any questions from the audience.
Thank you for the insightful presentation and talk, ma'am. We can take a couple of questions from the audience. So I have a question.
Mhm.
What is your opinion in prescribing Prism in younger children with high hyperopia with larger deviation?
Prisms?
Yes.
Oh, prisms. Okay. So let's assume we are talking about esotropia. Um, the first thing I would do, especially if they have hyperopia and esotropia, is prescribe the full cycloplegic correction and have them back for a follow-up in either 2 to 3 months. Once they come back for a follow-up, you measure the deviation with the correction. And if the magnitude of the deviation comes down pretty significantly, but if there still is a residual amount of deviation, then we usually consider doing bifocals to see if the bifocal helps, especially if the residual deviation is worse at near. We hardly ever prescribe base out prisms for young children, and if the esotropia, either with or without correction, is not accommodation induced, then we usually refer patients out for surgery. Refer patients out for surgery, especially because larger magnitudes of esotropia are more amblyogenic. So you want to correct that as quickly as possible. So in children under 3 or 4 years, we hardly ever prescribe prisms. I think there's one question in the chat. Um, why
It's from
why does
Anish.
esotropia tend to be more amblyogenic compared to exotropia? Ooh, that's an excellent question. So so exotropia by nature tends to be more intermittent in young children, and the more intermittent the deviation, meaning the less time spent during waking hours without strabismus, it aids in vision development. Whereas esotropia, on the other hand, especially if it is not associated with hyperopia or induced by refractive error, it tends to be more constant. And if the deviation is more constant, as you can see, based on where the visual angle is and where the visual axis is pointed in one direction versus the other that's staying on the target, it causes cortical suppression, and it affects vision development. That's why more likely to. So the more uh, constant it is, and the more frequent it is more likely to induce amblyopia because it interferes with vision development, especially during the first 6 months to 1 year of life. So the next question is, I would like to know how to prescribe glasses with high visceral astigmatism, such as +2, +3 cylinder. Okay. So the question, so the +2, +3 is for astigmatism, right? Okay. So if you have patients with a combination of hyperopia and high astigmatism, for hyperopia, what you prescribe still applies, right? We talked about prescribing partial correction versus full correction. That still applies even for combined refractive error. For higher astigmatism, I do not mess with it. I always prescribe all of it. All the astigmatism goes into the prescription the first go around. And at follow up, you really want to talk to them about whether the child is wearing the glasses, how often are they wearing the glasses, are they tolerating well, because it really gives you insights into how your prescription is working for the child on a day-to-day basis. And then you take measures of vision, all of the visual functions, and see how the glasses are helping. And if you get the sense that the prescription is really strong for the child, then you could cautiously cut back on the prescription. But I usually, as a starting point, prescribe all astigmatism, maintain anisometropia, and then for hyperopia, whether it's partial or full correction is based on whether there is ESO deviation. I hope that helps.
Hi, ma'am.
Hi.
This is me, Gauri.
Yeah.
I have a doubt, ma'am.
Uh-huh.
Have you ever crossed visual agnosia children, like probagnosia, midline shift syndrome children?
Have I ever what?
Have you ever checked refraction, visual acuities, likewise, ma'am? How to handle the
Yeah.
children?
Yeah. I mean, I think it's really difficult, whether we are talking about patients with agnosia, we're talking about patients with cognitive intellectual difficulties. It's really difficult to measure vision in a reliable way that helps you prescribe glasses in a traditional sense, right? So you have to use your objective measures, your objective ways of doing, retinoscopy, whether it is dilated or before dilation, and you get a rough estimate of what their refraction is, and then you determine whether or not it's significant for their age. And we know from studies that patients with intellectual difficulties, cognitive difficulties, and intellectual disabilities, they tend to have higher refractive errors. And, I work at a hospital based practice, so we see a lot of these children because they are in general not in good health and they need multiple specialty teams that care for them, right? So we see them in ophthalmology. The biggest challenge is that when you see a really high prescription, so I've seen kids with +8, +8.5 diopters of hyperopia, and I have never seen them once come in with glasses because they just would not tolerate glasses. Just wouldn't. Even if you undercorrect their hyperopia, because of all the sensory challenges they have, they just don't tolerate glasses. And I've had some parents who frankly tell me that having them keep their glasses on is not a priority because they have other significant health issues that they're battling with for their child, that they know the child is supposed to wear glasses. um, they have tried and it just hasn't worked. So I don't have a
Thank
good
you.
answer for you, except that I sympathize with you that this is a very challenging population and that they are more likely to have refractive error problems. And we try our best to prescribe glasses. Sometimes when we talk about standard of care, sometimes I deviate from that, meaning I sometimes do partial astigmatism. to see if that they could tolerate, I would cut more than the amount of hyperopia that I'm typically comfortable with cutting in hopes that they would adhere to the glasses. It just doesn't work. So it's a constant battle and it's just hard.
Yes, ma'am, I understood, ma'am. Just I want to know about your opinion in those children, ma'am. Thank you, ma'am.
Yeah.
So another question which is asked through Google Form by the attendees, do we have any prescribing guidelines for children with CVI?
Not to my knowledge, but I know that we have a working group in our National Eye Institute that actually has started to show interest in the CVI population and are putting together working groups and talking about what are the best practices and minimum standards for evaluating these patients. I'm hoping that, this expert group that actually has the best collective clinical knowledge of working with CVI patients in this world, they'll be able to come up with recommendations. So for now, I'm not aware of any prescribing recommendations just for CVI patients. The general sort of rules of thumbs for refractive error applies to this population for now.
Questions? Okay, due to time aspect, I would like to wrap up. Thank you, ma'am, for your consideration and time in spite of your busy schedule. Before closing, I will post a quiz link in the chat box. Please do fill the quiz link to get a certificate which is signed by both Acchutha and OCI. If you like to see our older sessions videos, it is uploaded in our YouTube channel, Acchutha Institute of Optometry. Please do subscribe. Thank you, ma'am. Thank you all.
Bye, everyone. Thank you for coming.